Our guest speaker, which promises to provide a very interesting discussion. A few things, a few comments that we started about 8.5 years ago, providing information and reminding you to celebrate people who have changed the way we think about medicine, history, and life in general. So a couple of people that I want you to remember today are Kiyoshi Shiga. Kiyoshi Shiga died on this day at age 85 in 1957. He was a Japanese bacteriologist who discovered in 1897 the dysentery bacillus shigella that we all know. He actually also developed dysentery antiserum in 1900. He, after that, worked on trypanosomiasis. He worked on tuberculosis, he worked on leprosy, he worked on beriberi. He was really involved in a lot of research that set the stage for much of what we do for these infectious diseases today. But today is about neurology. It's about the brain. So we have to remember Arvid Carlsson, C-A-R-L-S-S-O-N, who was born on this day back in 1923. Arvid Carlsson was a Swedish neuroscientist who shared the Nobel Prize in 2000, Nobel Prize for Physiology and Medicine. He shared it with Paul Greenwald and Eric R. Kandel. And what this group did was to work on the signal transduction of the nervous system. They actually made tremendous contributions to understanding of synaptic transmission. They discovered the roles of serotonin and dopamine as neurotransmitters and important electrical transmission in the brain. His work led to the development of levodopa. And later on, he introduced the first reuptake inhibitor called zimelidine, which led later on to the development of Prozac and Zoloft. So that's interesting. But today, you may have noticed, was the birth of Virginia Woolf, the English writer. She was born on this day back in 1882, and she said this: "My own brain is to me the most unaccountable of machinery, always buzzing, humming, soaring, roaring, diving, and then buried in mud. And why? What's this passion for?" So hopefully we'll understand a little bit what this passion is for and how with our guest speaker of today. So yes. This doesn't always happen. I'm never interrupted.
And I'm not a pushy person or anything, but this is another historic day. This is the last time that Dr. Jesse Roman will be introducing grand rounds for the University of Louisville, and I can think of no better venue for us to bid him farewell than this platform that he worked so hard to develop to make it a place where we could exchange ideas, discover what each of us is doing, and have a weekly time of camaraderie. Jesse, thank you for your service.
Thank you so much. Appreciate it. Thank you. Wow. Thank you. I should take a selfie. Thank you so much. I don't want to diminish at all your contribution.
Yeah, that's going to be hard to follow.
Thank you so much. Thank you, all of you. So I want to introduce Brittany Chapman. Brittany Chapman is a colleague of ours here at UofL. She's assistant professor in the Department of Neurology. After obtaining a bachelor's degree in psychobiology at Centre College, she obtained her MD at UofL and then went on to undergo internship in internal medicine training at University of Cincinnati, did adult neurology training at UNC in Chapel Hill, where she also did a sleep medicine fellowship. And she did a neuropsychology clinical fellowship at The Ohio State University and came back to us, I think, in 2015. She's very engaged in education. She's director of the neurology clerkship. She's involved in problem learning and several other efforts, and her interests you will hear about today. And hopefully she'll answer that question that Virginia Woolf had. Thank you for joining us.
All right. Thank you. So thank you so much for having me here today. As you can tell from the talk, I'll be talking about approach to epilepsy. This is the majority of my practice here at UofL. And I have a particular interest in treating women with epilepsy, and so that's another thing that I wanted to touch on today. So our discussion outline, I'm going to start with some definitions and also detail the workup for seizures. We're going to discuss treatment options, including medications, surgery, and the devices that are now available for epilepsy. and then again review the special considerations for the special population of women with epilepsy. So according to the Epilepsy Foundation website, about 3.5 million people in the United States have epilepsy, and that's 150,000 new cases per year. So this is quite a big patient population in the U.S. So what is an epileptic seizure? So an epileptic seizure, the official kind of definition is it's a transient occurrence of signs and symptoms due to abnormal excessive or synchronous neuronal activity in the brain. So essentially a seizure can be anything. So the clinical manifestations of a seizure are dependent on kind of two main things: where in the seizure, or where in the brain the seizure is located, and how much of the brain is affected. And so you're probably more familiar with maybe a generalized tonic-clonic seizure, which presents as a convulsion, or sometimes people can have the automatisms associated with temporal lobe seizures with mouth chewing or some dystonic posturing of the limbs. But essentially a seizure can be anything. I've had patients whose seizures manifested as certain songs, or people can hear or taste or see things as well. Now, we kind of further define seizures a lot of times in provoked and unprovoked seizures. So it's kind of important to know the difference between those two. So provoked seizure occurs in the contents of some sort of acute brain insult. You can identify what that etiology is, you can treat it, reverse it, and prevent it from happening again. And patients with provoked seizures are not at increased risk of developing epilepsy down the road. And unprovoked seizures where you cannot identify an underlying cause, and those are the people who we generally have a higher risk of developing epilepsy. So the more common causes of provoked seizures include alcohol withdrawal, maybe an adverse side effect to a medication. Bupropion tends to be a common offender. Certain electrolyte abnormalities. So when patients present in the emergency department, these would be important things to check to make sure that they're not provoked seizures due to hyponatremia or something like that. Or it could be a side effect to a recreational drug. So what is epilepsy? And I have a feeling a lot of my patients, there's a lot of misconceptions about what epilepsy is. People say they have a seizure disorder. What does that mean? They have seizures, but they don't have epilepsy. And so I think it's good for patients to know if they have epilepsy that they have epilepsy, because otherwise I think that kind of prevents them from seeking out certain resources or maybe even interacting with foundations like the Epilepsy Foundation. So a few years ago, the International League Against Epilepsy kind of redefined what epilepsy was. So traditionally, we said that epilepsy was someone who had at least 2 seizures in their life, and those seizures were separated by 24 hours, and these are unprovoked seizures. But there are populations of patients who may have had 1 seizure, and we feel like there's an increased risk of them having another seizure, so we may want to identify them as having epilepsy as well, so that people feel comfortable initiating treatment on them. So maybe a patient had 1 unprovoked seizure, and we think they're at high risk of having another seizure, and we'll talk about what things may make us think that. Or maybe we diagnose an epilepsy syndrome. So perhaps a patient has 1 seizure, their clinical presentation fits consistently with maybe juvenile myoclonic epilepsy. The patient is an adolescent, they had a generalized tonic-clonic seizure in the morning, they described some early morning myoclonus. You get an EEG, it shows the classic 4 Hertz spike and wave. You can label them as having this epilepsy syndrome, and you wouldn't want to wait till they had another seizure before you initiated treatment. So the workup for epilepsy includes head imaging. So when patients present, usually in the acute setting with a first-time seizure, a lot of times we go to head CT first. It's rapid, widely available, cost-effective, and about 1/3 to 1/2 of patients who present to the emergency departments with a new onset seizure have some sort of abnormality. And so this is a CAT scan that shows subarachnoid hemorrhage, which can present with seizure. It's very sensitive for blood, so epidural hematomas, subdural hematomas, other intraparenchymal hemorrhages, gross trauma, hydrocephalus, or large structural lesions, but it's not very sensitive to other things. It only picks up about 30% of focal lesions that are associated with epilepsy. So generally, in the non-urgent setting, we rely upon MRI. And it's more useful and gives us a better detailed picture of the brain. And typically, when we are imaging patients with seizures, we want to use the stronger 3 Tesla magnet. And it picks up about 25% of patients who present with seizures have an abnormality on their MRI. So it's important to know that most patients don't. And I think a lot of times when patients have seizures and they come to the clinic and they get this workup and everything is normal, even though I think that's a good thing, a lot of times they feel a little let down or feel like they don't understand or they're not getting answers. So I think it's, again, important to let them know that most of the time the MRI is normal. Now, the most common abnormality that we generally see in adult patients is mesial temporal sclerosis. So this is one of the more common causes of intractable epilepsy in adults and responds very well to surgical intervention. And so this MRI here shows a good example of mesial temporal sclerosis. So the hippocampus is atrophied. You see a lot more space around the hippocampus than you do on the other side. You lose internal structure, and there's also increased signal intensity in that as well. So other than mesial temporal sclerosis, there's other epileptogenic lesions that we're looking for on MRI. You can get malformations of cortical development. So here you see a nice example of focal cortical dysplasia. Down here are some gray matter heterotopias. So these are migrational disorders that patients are born with, and for whatever reason, years later, they start having seizures because of those lesions. You can see encephalomalacia from remote brain injuries. A lot of times it's more the low-grade tumors that present with seizures than the high-grade tumors, so things like gangliomas or DNETs. Intracranial vascular abnormalities can cause seizures as well. AVMs, cavernous malformations that have the typical popcorn appearance here. This is a pretty large one. They're very epileptogenic. And then worldwide, neurocysticercosis is a very common cause of epilepsy. Not as common here. So the other thing we do are EEGs. So unfortunately, EEGs are not very sensitive, but it is one of the tools that we use a lot to evaluate. So why do we do EEGs? Say someone has some sort of spell. We get consulted a lot. They have some sort of episode that may or may not be a seizure, and so we get an EEG to help kind of differentiate between maybe an epileptic seizure versus something non-epileptic. Or we think the patient does have a seizure, and we want to further classify what type of seizure they may have had. Was it a focal seizure or generalized seizure? For some patients, we may consider surgical intervention for their epilepsy, so getting EEG is helpful for localizing the seizure focus. Or in the acute patient setting, if someone is altered and we're concerned about a status epilepticus, we can hook up an EEG and evaluate then. So there's several different types of EEG. So a routine EEG provides kind of a snapshot of the brain. It's usually a 20, maybe 60-minute recording. And typically patients aren't having seizures during this time. But what we're looking for, interictal abnormalities during that time that would tell us the patient may have seizures. We also can do ambulatory recordings where the patients get hooked up to EEG and they can go home for a day or two and then bring the equipment back. And so that's good in certain situations. You're probably aware we can do a lot of inpatient monitoring in the hospital. We can have video with that as well. And then we do invasive monitoring for our surgical patients where the EEG electrodes are either on or in the brain. Now, to increase the yield for these EEGs, we do activating procedures. Hyperventilation tends to trigger absence seizures in patients, younger patients, kiddos that generally have childhood absence epilepsy. We do photic stimulation. That can trigger abnormalities in patients with photosensitive epilepsies like juvenile myoclonic epilepsy. And then we utilize sleep deprivation as well. I think that's for kind of two purposes. One is we like for patients to sleep on the EEG, so if they're sleep deprived, they're more likely to fall asleep, and that tends to bring out more abnormalities. We tend to see those types of things, interictal abnormalities at sleep-wake transitions, and then during sleep as well, generally kind of usually around like stage 2 sleep. And also sleep deprivations can sometimes trigger things as well, so that's helpful. So only about a third of initial EEGs are abnormal. So again, the yield is not very high, but if it is abnormal, it's very helpful. If you're able to get the EEG within 24 hours of the seizure, it increases yield to about 50%. But if it's not normal, it's not exclusive for a seizure, and so I usually tell patients if the EEG was normal, it actually wasn't very helpful. And so you can see here, this is something that we're looking for interictally, which means between seizures. And so this would be an epileptiform discharge in the right, yes, in the right temporal lobe. So the patients don't feel these, they don't have any clinical manifestations, but normal brains should not have these, and so these are the types of things that we see in patients that have seizures. So anti-epileptic drug treatment, so when do you start? So you start someone on a seizure medicine if they have epilepsy. So again, traditional definition is someone's had 2 seizures 24 hours apart, unprovoked seizures, or they've had 1 seizure and you think that they're at high risk for having another seizure. So those things usually include abnormalities on the workup. So if they had a strongly epileptogenic lesion on the MRI after 1 seizure, you'd probably want to start them on a seizure medicine. If you saw, something like this on their EEG, you'd probably want to start them on a seizure medication. If they had neurological exam abnormalities, or maybe they have a history of some sort of trauma in the past, like a history of an old stroke. Strokes are the most common cause of epilepsy in the elderly, and they potentially can be epileptogenic later in life. Or interestingly enough, the seizure occurred out of sleep. That increases the risk of the patient having another seizure. So there's kind of a classic study by Quan and Brody that we refer to a lot, talking about what happens with treatment. So if you start someone on a seizure medication, about 47% of patients will stop having seizures with that seizure medicine, so a good chunk of patients. But if they continue to have seizures and you try a second seizure medication, you get another about 13% of patients will stop having seizures. But then if you try a third medicine, if they're still having seizures, or a fourth medicine, their chances of becoming seizure-free on more medication trials is less than 5%. It drops off very dramatically. And so one of the things that I wanted to kind of talk about today is what are those more aggressive options to reach that goal of seizure freedom? So again, our treatment goals are seizure freedom. I don't want the patient to have any seizures, but also you don't want them to have side effects to the medication. And so for some patients, that's a very easy goal to attain, and for other patients, it can be a lot more challenging. And treatment is based on several factors. So what type of seizure does the patient have? Do they have a focal onset seizure or a primary generalized seizure? What's the side effect profile of the medications? What are the patient's comorbidities? Are you able to pick a good fit medication for that patient? What are the drug-drug interactions? And then safety and pregnancy is another big one to consider in females of childbearing potential. So here I have examples of EEGs. So this EEG is kind of similar to the EEG that we saw earlier. This patient has, this is a left temporal epileptiform discharge. So what this EEG is telling me is this patient probably has seizures, and they probably start in the left temporal lobe. Now, they may spread, and the patient may have a clinical generalized seizure, but this tells me that it probably starts in one focal location. Now, this EEG looks a lot different. This shows primary generalized discharges. When I see this on the EEG, it tells me this patient has a primary generalized epilepsy, and that's important to know when it comes to the seizure medications. So there's a lot of seizure medications, and several of them have come out in the last few years. So some of these names may not be particularly familiar to you. And I left a couple of medications off. Ezogabine, which is Potiga, I think is coming off the market because it turns people blue. And Tiagabine, Gabatril, is just not used very often, and so I think they're going to stop making that. I've also left off some of the extended release versions of medications. So there's an extended release topiramate out called Trokendi, and there's an extended release oxcarbazepine out called Oxtellar. But we essentially divide the seizure medications in 2 broad categories. We have broad spectrum medications and we have narrow spectrum medications. So the broad spectrum medications are nice because they treat any seizure type. So, most commonly a patient comes in, say they've had a couple seizures and you want to start them on a seizure medicine. Their MRI is normal and their EEG is normal. You don't know what type of seizures they're having. You may suspect clinically based on their presentation, but you don't have any definitive evidence. And so picking a medication from the broad spectrum category is very helpful because you can't go wrong. It's going to treat any type. Now, the narrow spectrum medications are generally for focal onset seizures, and some of these can actually make primary generalized seizures worse. The only kind of caveats are vigabatrin isn't necessarily for focal onset seizures. It does have an indication, but it's mainly used for infantile spasms. Rufinamide, which is Banzel, is used for Lennox-Gastaut syndrome, and ethosuximide is particularly for absence seizures, and you wouldn't use it for really anything else. And this is important to know because I'm sure a lot of you maybe use some of these. You may use pregabalin or gabapentin for painful diabetic neuropathy. And so it's important to know that these seizure medications, if the patient has a primary generalized epilepsy, could potentially make their seizures worse. So side effects count. I'd like to think about the negative as well as the positive side effects. So we have AEDs that are helpful for mood. Lamotrigine has antidepressant effects, and valproate can help with mood stabilization as well. There's AEDs that help with migraine or different pain syndromes, so you can maybe kill two birds with one stone with some of these medications. There's AEDs that help with weight loss if you have a patient that has a problem with weight. I think these are important for drug-drug interactions. We have one enzyme inhibitor, valproate, and a long list of enzyme inducers. So I think kind of the main interactions you have to worry about that I think are most concerning are maybe anticoagulation with Coumadin. If these medications are added or subtracted, that can affect management of the INR. And something that I always pay attention to are oral contraceptive pills, and we'll talk more about that later. But these medications, oxcarbazepine and topiramate, these are dose dependent. So at lower doses, they're not necessarily inducing the hepatic enzymes. But both the enzyme inhibitors and the enzyme inducers can increase the risk of bone loss. So if the patients have been on these medications for at least 5 years, they need to have a DEXA scan, and then that needs to be repeated every 5 years. So about half the seizure medications cause Stevens-Johnson syndrome, so that's another thing that I always have to warn patients about. A good chunk of them can cause hepatotoxicity, so those would be medications that clearly you'd want to avoid in patients who have pre-existing liver disease. There's medications that can cause leukopenia or anemia, so we have to monitor CBCs for those medications. There's medications that you need to dose adjust in renal failure, and this tends to pop up in the hospital a lot. Levetiracetam is a medication that's used pretty frequently, and that needs to be renally dosed, so that's always something to consider in patients in the hospital who may or may not have problems with their renal function. Another consult we get in the hospital quite frequently is patients that are on gabapentin and have renal failure getting myoclonus. That's very common. You get gabapentin toxicity, and patients will have myoclonus. There's medications that you need to dose reduce in hepatic disease, and then about 4 or 5 medications affect the EKG. So it's mainly the ones that affect the sodium channel that can affect the PR interval or the QT interval, and so you may want to monitor with EKGs. I do that more frequently with lacosamide because it can affect the PR interval, and also want to consider that in patients that have cardiac arrhythmias. So key side effects, again, levetiracetam, I feel like people love vitamin K, especially in the hospital, but it really has a lot of problems with mood disturbances. Very common, it causes irritability, moodiness, extreme depression. I have a lot of patients I end up having to switch off of levetiracetam because of mood disturbances. I've had a few patients end up in emergency psych for mood disturbances from levetiracetam. Oxcarbazepine and carbamazepine are known to cause hyponatremia, which are age and dose dependent. Valproate has a long list of side effects, but the main ones to know are tremor, weight gain, and hair loss. And it's highly teratogenic. Again, we're going to talk a little more about that later when we're talking about women with epilepsy. Phenytoin causes the classic problems with the gums. It can cause cerebellar atrophy. Kidney stones can be seen in topiramate and zonisamide, so I generally don't start those medications if the patient has a history of kidney stones. And then there's a kind of a relative drug-drug interaction between metformin and topiramate causing a metabolic acidosis. And vicabatrin, which again is usually used for infantile spasms, causes visual field deficits. So if that medication is going to be prescribed, you have to go through this particular program, and the patient has to be on a very structured schedule where they get their visual fields checked by an ophthalmologist so often. So this, I think, is maybe one of the most important slides that I'll talk about today is contraception and the interactions with the seizure medications, because a good chunk of my patients are women of childbearing potential, and I get asked about this a lot from the residents, from their OBGYN, and it's, I think, a very important thing to know when you're trying to prevent pregnancy. So the enzyme inducers decrease the effectiveness of the combined oral contraceptive pills. So if they're on carbamazepine, their birth control is not going to work. They're going to have to use another method, and it can also affect the implants, like the Implanon and the Nexplanon. Now, lamotrigine in particular and perampanel, that's a new one, Fycompa, they're not enzyme inducers, but they actually can decrease the effectiveness of the progesterone-only mini pills, so that's an important one to know as well. Now, the pills themselves can have an effect on the seizure medication. So the combined pills can actually decrease lamotrigine and valproate levels, and that one is not an absolute contraindication. So if I have a patient that's well controlled on lamotrigine and maybe she wants to start birth control pills, what I tend to do is get a level before she starts and then a level after she starts, and if it drops, then dose adjust. But during that time, there is, I guess, a possibility if she falls below a therapeutic range that she could potentially be at risk for seizures and may even want to avoid driving at that time. And the vaginal ring, that can decrease lamotrigine levels as well. And there's some studies that show the transdermal patch can actually worsen seizure control. So the kind of the easiest go-to thing that if you wanted to make a recommendation on contraception for women would be some sort of IUD, either the copper or even the hormonal releasing one, Skyla or Mirena. But then that comes with pros and cons as well. So that, I think this is usually a long discussion with me, a long discussion with our OBGYN about what's best for the patient. So none of the seizure medications, we can't say any of the seizure medicines are necessarily safe in pregnancy, but some are relatively safer than others. So they're all class C or D. And the only thing we know about what happens during pregnancy is because of the North American Anti-Epileptic Drug Pregnancy Registry. So this is a registry. If women happen to be pregnant on seizure medications, they can call and report if they have had any adverse side effects. And so that's the data that we usually quote is from that registry. So if I have a patient that becomes pregnant on a seizure medication, then I usually encourage them to contribute to that registry as well. So overall, the risk of seizures are worse than the risks of the medication. So seizures can cause trauma that put the pregnancy at risk. It can cause a lot of issues with the fetal heart, causing decels, bradycardia. That's been seen in focal seizures as well as eclamptic convulsions. If the patient has very uncontrolled seizures, 5 or more seizures during the pregnancy actually can decrease verbal IQ for the baby. They can have problems with for gestational age. There's a higher risk of maternal death, an increased risk of preterm labor. So we always want to control the seizures and have pregnancies be planned, which never happens, but we try. So like I said, in general, the risks of the seizures are worse than the medicine. So if the patient becomes pregnant, we want them to continue their medications, just knowing and educating them about the risks associated with the medications. So if the patient's seizure-free for about 9 months, then the chances of them becoming having seizures during their pregnancy is very low. So again, it's always important to try to get these patients to kind of plan their pregnancies and try to get the epilepsy under control before then they start trying to get pregnant. And what we try to do is get them on the least amount of medication as possible in anticipation of this pregnancy to kind of lower all the teratogenic risks. But once the patient is pregnant, we don't want to make any dramatic changes because the last thing you want to do is then throw their epilepsy off during the pregnancy and them having a lot of breakthrough seizures. So the risk of major fetal malformations, so these are ones of surgical, functional, or cosmetic significance in the general population of any woman is about 1 to 3%. But in females that are on seizure medications, it's about 5 to 14%, depending on the drug. So the 14% is an outlier, that's Depakote. And these usually occur by 8 to 10 weeks of pregnancy, which is pretty early on. So you see mainly the structural problems in the first trimester and more of the cognitive problems due to exposure throughout the pregnancy. So valproate, I think, is the biggest offender that's been more recently associated with lower verbal IQ and autism. And that tends to be dose dependent. So on patients on lower doses, that risk is not as high, but on higher doses, that risk jumps up quite a bit. Phenobarbital is associated with cardiac malformations. Topiramate, I think when I was in residency when it got knocked down from a category C to a category D because of the problems with facial clefts that started. Carbamazepine is associated with spina bifida, and phenytoin has problems with hypospadias and cardiac defects. So levetiracetam is one of those that we tend to use in women of childbearing age because it's a relatively low incidence of malformations. There's only been 2 reported that may or may not necessarily have been associated with the drug. Lamotrigine is another one that we tend to use in pregnancy, but it kind of has a dose-dependent effect, so that it jumps up a little bit with higher doses, and carbamazepine as well. So we always recommend women of childbearing potential to be on folic acid, somewhere between 1 and 4 milligrams. There's no known specific dose that is better than the others. I usually recommend 1 milligram. And this is a lot more than what's in a multivitamin. This is a lot more than what's in a prenatal vitamin, so you have to give a prescription strength of folic acid, 1 milligram. It decreases the risk of neurotube defects. It's also been associated with decreasing the verbal risk of lower verbal IQ and spontaneous miscarriage. And because of these issues with birth defects, we recommend a high-level ultrasound at 14 or 18 weeks. Now, if the patient had a birth defect with 1 pregnancy, the chances of having a malformation with second pregnancies is actually really high. So that's another important thing for the patients to know. And as you can see here, valproate in general has a lot higher incidence of major malformations. The other ones are relatively lower. And then this is the cardiac malformations seen with phenobarbital. So what I tend to do in patients, if they are well controlled, is I try to anticipate pregnancy and get at least 1 or 2 therapeutic levels for the patient. So I don't really care if the level is in the therapeutic range, but I want to know what that patient's level is. So if they're well controlled and they're on lamotrigine and their level's 4, then I want to know that in case they get pregnant, then I can follow that level and try to keep their medications level around that value during the pregnancy. So, for their yearly follow-ups, if they're doing well, I check a level, so I have that on hand in case 2 months later they call and say, hey, I'm pregnant, so I can have that. And then what I usually do is check a level once a month during their pregnancy, and if it tends to drop, I can dose adjust. And that tends to happen with lamotrigine and oxcarbazepine due to induced metabolism with estrogen. And it happens pretty bad with lamotrigine, actually. I've had a patient where I had to double their dose, and they end up still having some problems during their pregnancy. So if you do end up having to increase their medication dose during pregnancy, you need to be aware of what to do when they have the baby, because they can become toxic pretty quickly, and so the recommendations are to kind of gradually taper it over the 10 days. And maybe you want to leave them on a slightly high pre-pregnancy dose, or maybe you want to leave them on the previous dose because of the problems with sleep deprivation, which may provoke some seizures in patients during that time when they have the new baby. And we always encourage breastfeeding. This is another one that I think is a misconception that I hear from patients all the time, that they're told that they shouldn't breastfeed. But we always recommend breastfeeding. And there's a study called the NEED study that showed that babies that were breastfed had higher IQs. So general seizure precautions, we'll talk about driving on the next slide. But we tell patients, just in general, use good judgment when you're doing certain activities, and avoid those activities that if you were to have a seizure, you could maybe hurt yourself or someone else. And I can never list everything, and most patients don't like to live in bubbles because you could really go to the extremes on this, but these are kind of the standard precautions. We want them to be aware of the risk of drowning, getting burned, falling. I actually had a patient that was a painter that fell, ended up having a spinal cord injury because of a seizure. Not kind of operate heavy machinery, power tools, and sleeping in the prone position has been associated with sudden unexpected death in epilepsy, or SUDEP, which is not something I'm necessarily going to kind of touch base on, but that's what increases the mortality in patients with epilepsy. But I get questions all the time, can I do this, can I do that? And I can never answer them. I never know. Someone wanted to do laser hair removal, and the place told them they couldn't do it. I have no idea why. I don't know why they couldn't do it. So roller coasters, they always come up with something, and I never really have a good answer a lot of times. So it's kind of always a balance between the risks and the benefits of what the patient wants to do. You know, do they want to live their life and do what they want to do, or kind of have some things restrict them? And then for new moms, we have some additional precautions we usually like to educate them about. So the family members, maybe they can help out with some nighttime feeding so the patient can get some good sleep. Maybe don't bathe the child by themselves due to the risk of drowning with the baby. Maybe change the diapers on the floor so there's a risk of falling from the changing table. Avoid stairs. I'm not sure how practical that one is. Use strollers, and don't have the infant sleep in the bed with them. So this map is from 2002, but I don't think things have changed any since then. So driving is state dependent, and so in the state of Kentucky, you see that we're yellow. Patients can't drive within 3 months of a seizure. Now, I like to remind patients, because that seems kind of harsh, that this is actually the most lenient of all the states. As you can see, there's several orange states where the patients can't drive for a year. And so that's pretty bad. I'm not really sure why it's a year. And then the pink states are up to the physicians. And usually when it's up to the physicians, they usually go with somewhere between 3 and 6 months. So it's always important to document that from a medical legal perspective, that the patient knows that. So there are other comorbidities in patients that have epilepsy that we need to be aware of and to be screening for. So there's tends to be cognitive impairment. I get a lot of complaints of memory problems. There's problems with attention, executive function. A lot of mood disorders are a lot more prevalent in this patient population, as well as suicide. Migraines are a big one. There's a huge comorbidity with migraines, and up to a third of patients have obstructive sleep apnea. And we're not exactly sure what the relationship for that is, but it is a lot more common in patients with epilepsy, and they don't have the traditional risk factors of obesity and that sort of thing, or excessive daytime sleepiness. It doesn't correlate with BMI or like their Epworth sleepiness score. And there's also an increase in mortality. It's 2 times the general population, and that's due to Dept, the sudden unexpected death in epilepsy. So just because a patient is started on seizure medicine doesn't mean it can't be stopped at some point in their life. So when is it okay to stop seizure medications? So standard of care is after the patient's been seizure-free for 2 years, we kind of discuss the risks and benefits of potentially coming off the drug. Not everyone is a candidate, but we kind of go over things and go over their favorable and unfavorable indicators. So it's not exact science of guessing who's going to not have seizures if we stop their medications. And sometimes I feel like I have really good candidates. I had a patient recently who just had a few seizures, respond really well to 1 seizure medication, didn't have seizures for 2 years. MRIs were normal, EEG was normal, exam was normal. We stopped his medicine, and he came in the hospital 2 months later with a seizure. So sometimes you can be surprised. And so there's certain factors. So generally, patients that tend to present in childhood or have certain childhood epilepsies like childhood absence or benign rheumatic epilepsies, they tend to grow out of that epilepsy. So they're generally good candidates to wean off. And usually, again, like I kind of mentioned, they have infrequent seizures. They respond well to low seizure medications. Those are good factors that would tell me the patient probably or hopefully would not have a seizure if we stop the medications. But there are several unfavorable factors, and that essentially is adult onset. You find an etiology, so say you did an MRI and saw one of those epileptogenic lesions like focal cortical dysplasia, or the patient has a syndrome like juvenile myoclonic epilepsy that has a high relapse rate of 90%, and so typically these patients need to be on medications lifelong, and their seizures can be very sporadic. I had a patient once who had JME, who had been weaned off their seizure medication and went seizure-free for 2 years and then end up having a seizure. So, you know, they can go a long time without having any seizures. And so if they have EEG abnormalities or abnormal exam or MRI, these would tell me maybe the patient's at a pretty high risk and they should stay on a medicine. So for example, if it's a patient who had a history of a pretty significant traumatic brain injury, maybe they had a subarachnoid hemorrhage, a skull fracture, that patient probably needs to be on seizure medication lifelong. So what happens when 2 drugs fail? So we talked about earlier that after someone has tried at least 2 seizure medicines, if they still keep having seizures, their chances of becoming seizure-free on more medication trials is less than 5%. And so we have a lot of terms for this because we want to identify this patient population and try more aggressive options. So these all mean the same thing: intractable, medically refractory, treatment resistant. If you heard any of those terms, they all mean the same thing. It means the patient's has tried at least 2 seizure medicines and they keep having seizures. Now, you need to make sure that the medication was appropriate for the seizure type. So if someone had adult onset temporal lobe epilepsy and you're giving them ethosuximide, which is only indicated for absence seizures, you wouldn't want to call that a treatment failure because that wasn't the right drug for the patient. And there's also this term that we use, pseudo-resistance. If a drug is stopped early due to a side effect, you're not actually giving that drug a good enough trial to see if it actually would have had the anticonvulsant effect that you were looking for, and so you wouldn't want to call that a true failure. So if someone was on lamotrigine and a very low level developed a rash, and you stop the drug, you wouldn't call that a failure. But if you've tried 2 medicines and they keep having seizures, you want to do something different. Now, a lot of times we want to take a step back and see if the patient actually has seizures. So about 25% of patients actually aren't having epileptic seizures, and that's why their seizures are still going. So sometimes we put them in the epilepsy monitoring unit and we find out that they have cardiac arrhythmias, or maybe they are having psychogenic spells, and that's why that they're not going away with seizure medications. So that's why standard of care is to consider more aggressive options. So we want to consider epilepsy surgery for focal seizures. We're going to talk a little bit about the devices for epilepsy. There's diet therapies. You can refer a patient to a nutritionist and try the ketogenic diet, which seems to be pretty trendy now in non-epilepsy patients. The modified Atkins, low glycemic index. Maybe the patient wants to enroll in a clinical trial and get an experimental drug. And I did have CBD oil on there, but I took it off because I put something on the thing saying I wouldn't talk about anything off-label. But that wouldn't necessarily be an unreasonable option in certain patients as something to try if they continue to have seizure despite your best efforts with other things. So epilepsy surgery, what we want to do is put them in our epilepsy monitoring unit, which is on the 8th floor of the hospital, hook them up and have them have seizures. And so 1, we want to confirm that they're having seizures, and 2, we want to know where their seizures are coming from. And so this shows an EEG that shows a seizure occurring starting here in the left temporal lobe, and you can see it kind of build up. And if the MRI is negative, if you don't see anything to target for surgery, a lot of times we want to correlate this EEG data with some sort of abnormality on imaging. So we may use PET scans that shows a hypometabolic area in the temporal lobe. It seems to be pretty good for temporal lobe epilepsy. And then sometimes we do ictal SPECT scans. Those are done in the epilepsy monitoring unit, and we inject a radio tracer while the patient is seizing, and it'll show an increase in blood flow where the seizure is coming from, and that actually has a pretty high sensitivity and specificity as long as you can get the injection in pretty quickly. And so there's a lot of things that our neurosurgeons here can do. Dr. Niemann is the neurosurgeon that does the epilepsy surgeries. So if there is a lesion, he can take the lesion out. If you want, you can take out a whole lobe, like a temporal lobectomy would be a common thing, especially for mesial temporal sclerosis that we talked about earlier. You can do a corpus callosotomy, and that's done usually for drop attacks. You can do a functional hemispherectomy, which is more commonly done for kiddos with like Rasmussen's. Another option would be something called multiple subpial trisections. So I kind of relate this as a kind of a maze procedure on the brain. So there's certain parts of the brain that we don't want to take out. We call those that part of the brain eloquent cortex. Eloquent cortex are things like the primary motor area. You don't want to take that out and leave the patient hemiparetic. The primary visual cortex, you don't want to affect their vision, or their language area. So what you can do is do kind of these transections, and it kind of disrupts those epileptic fibers. Or we can do, Dr. Niemann can do a less invasive sort of laser ablation where he actually doesn't do any actual surgical resections and just kind of does the laser. So seizure freedom with surgery, it kind of depends on how long you follow the patient. So if you follow the patient for a year, their seizure freedom rate probably is going to look pretty good. But the longer that you follow patients, the more likely that they'll have a seizure, and so then the rates tend to fall off. The seizure freedom rates after surgery also are dependent upon whether there was a lesion or not. So usually the non-lesional cases are the more tough patients. A lot of times those patients have to have those invasive monitors where we do the subdural grids or the Dept electrodes in the brain. Those patients tend to do a little worse. But seizure freedom rates are pretty high, 50 to 70% with a temporal lobe resection, which is much higher than less than 5% with seizure medications. And so this is why this is standard of care now. And it's, I think a difficult decision for the patients to make. It's a very time-consuming evaluation. They have to undergo a lot of testing. It takes a long time, but overall, it seems to be worth it. Now, patients who are having seizures from the other lobes tend to not do as well. I had a patient that had a frontal lobe resection about 1.5 years ago and went seizure-free for about 6 months, but now his seizures are back, and so they tend to not do as well as the temporal lobe resections. So there's 2 devices I think that you should be aware of for epilepsy. So the first one is the vagus nerve stimulator, which you're probably more familiar with. It was FDA approved in the late 90s. So it is essentially a pacemaker-like device that's inserted in the left side of the chest with an electrode that wraps around the vagus nerve on the left. It's a pretty easy procedure. It's outpatient. The patient gets to go home that day. It's also FDA approved for treatment-resistant depression, and you can put it in kids as old as 4. And so you use this wand, and this is the tablet, to program it. And so essentially you tell it to give the stimulation, how strong the stimulation is, and how often you want to give the stimulation. So there's something called the duty cycle where it's on for so long and off for so long, on for so long, off for so long. And it's doing this all the time. And so kind of the initial settings is a duty cycle of 10%, which means it's on for 30 seconds, it's off for 5 minutes. And it's doing this all the time. And so the patients are getting stimulated about 2.5 hours per day. Now, they are given this magnet, and if they feel a seizure come on, they can swipe the magnet over the stimulator, and for some people that actually can stop the seizure or maybe make the seizure a little shorter. And then the newer device, this is the 106 device, and I just have this picture for scale. It has a tachycardia detection on it, so it assumes that if your heart rate jumps up real fast, you're having a seizure, so it'll give an extra stimulation then as well. Now, you can have an MRI. Unfortunately, you can't have an MRI in this field, but you can have an MRI in any other part of the body. We do have to turn the device off for MRIs, and that's just setting the currents to 0. It's very easy to do. And the battery tends to last several years. So there were kind of 2 initial studies that got this FDA approved. There's an international study and a U.S. study. This is the data from the international study. These patients were having 6 seizures per month. There were a little over 100 patients in this study, and what they did was everyone got implanted. Some people got high stimulation, some people got kind of low subtherapeutic stimulation, and there was a seizure reduction of about 25% in the high stimulation group. And you can see these are the more common side effects we see, and it's usually when the stimulator is going off, so it can affect the voice. Patients will have kind of a hoarse voice. They can have some coughing or shortness of breath with this. And then this is the U.S. study that had a few more patients in it, about 200 patients. One patient actually became seizure-free in this study, and there was a decrease in their seizures by about 28%. Surgery complications for this study, some vocal cord paralysis. That actually, one patient had some facial weakness, some fluid accumulation. With all surgeries, there's a risk of infection. What was great about this is that not only did they do well in the studies, which were only 12 weeks, but when they looked at some follow-up studies, the patients continued to have some improved efficacy. So what we see sometimes with seizure medications is we start medications and the patients do kind of well for a while, and then their seizures kind of come back. And we're not exactly sure why. I know patients tend to like to say that they developed an immunity, which I have to explain that they're not, but it's kind of this honeymoon type of period with a new medicine. But what was great about the VNS is actually patients tend to keep improving long-term. And they even had a lot of follow-up because this was came out, in the late 90s, so we even have some 10-year follow-up data that even showed improvements patients were becoming seizure-free. 25% of the patients actually became seizure-free, and most patients had a pretty significant reduction in their seizure frequency, up to an 80% responder rate, which is a 50% reduction in their seizures. Now, the other device that's a lot newer that you may not be as familiar with is responsive neurostimulation. This is produced by a company called NeuroPace. And we do provide this for patients. I think the University of Louisville was the first hospital in Louisville to implant one of these devices. I think we probably implanted maybe around 10 or so. So it's a generator that's actually surgically implanted in the skull that has 2 leads, and you just stick them where the seizures are coming from. So this would be for a patient that maybe is not a good candidate for surgery because they had 2 lesions. Maybe they have what we call dual pathology. The seizures are coming from 2 different spots, and so you can put these electrodes in 2 different spots in the brain. And so what we do is we program it and tell it what a seizure is. So what this is doing is this is recording EEG data. And so we get this data after it's implanted, we program it and say this is what a seizure is, and whenever it detects a seizure, it delivers a stimulation to stop the seizure. And so this is more invasive. This involves a craniotomy and putting these stimulators in the brain, and so the patients are usually in the hospital for a couple days after this. And so this had one double-blind sham study, so everyone got the device implanted. Some patients were turned on and some patients weren't. And these are patients that, a third of them already had surgery and were still having seizures. A third of them already had VNS and were still having seizures. So this is a pretty refractory group. And so after a lot of surgeries, just the surgery itself, seizure frequencies tend to go down. And so for both groups, after this implantation, their seizure frequency decreased. But then once the blue line is the treatment group, once their stimulator got turned on, they continued to have a decrease in their seizure frequency. And then the sham group, since their stimulator was not turned on, their kind of baseline seizure frequency bounced back up to the pre-implant baseline. And so this is kind of a busy slide. It just goes over the side effects. I think the major ones to talk to patients about is there a 2% risk of hemorrhage and about a 5% risk of infection. And in this study, some people actually had to have their stimulators removed. And so we have some prolonged data on this as well, and this kind of reflects what we saw with VNS, is the longer the patients have it in, the better they do. So by 6 years, we have some follow-up data that showed the patients had a 66 reduction in their seizure frequency, which is really high. So from practical info, so the patients are given a laptop and a wand, and what they need to do is they need to download data every day. A lot of times the patient or their caregiver can do that, and I can look at it online, which is helpful, and so between visits I can see what's going on. Now they have a magnet too, but it's different. What the magnet is to do is it's supposed to save the data with a clinical seizure. So if the patient feels like they're having a seizure, they swipe the magnet and it downloads their information on what the EEG looks like while they're having a seizure, so we can correlate their clinical seizures with what the EEG looks like, which is helpful information to have. It doesn't activate the device like the VNS does. And the patient's only getting stimulation when they're having a seizure, so they're getting less than 10 minutes of stimulation a day. The battery lasts several years, but unfortunately the patients have to go to the OR every time they need a battery change because they have to access the skull. And once the patients have this, they can't have an MRI anymore, which is, I think, an important consideration for certain patients. So hopefully I was able to kind of highlight what I felt was more important in today's talk. I think it's important to know when medications need to be started and who has epilepsy and what that really means, and that certain medications or certain people, their medications can be stopped. And there's a lot of seizure medication out there, and so I think it's important to think about drug-drug interactions and that sort of thing when you're picking certain medicines for certain people, especially with women with epilepsy. They're definitely a unique population where you have to kind of consider a lot of things, pregnancy, contraception, and that sort of thing. And persistent seizures are unacceptable. I think if someone is having seizures, we should always be doing something to help prevent them. So that's either medication changes, considering these more aggressive options. Obviously, we work with the patient and don't force them to do anything they're not interested in, but working with them and at least providing them with opportunities of things that can help them with their seizures. So, thank you.
Thank you, Dr. Chapman. Tell me a little bit about the mechanism of a seizure. Is this about overexpression of certain neurotransmitters or there's some cells that are more screwed up than another? What have we learned through the years and about the medications that are working? Why do they work?
Yeah, I don't think we know. I mean, honestly, there's still a lot that we don't know about this. I mean, there's a lot of animal models, and this is kind of getting a little out of my clinical area of expertise, but there's animal models for seizures, but we don't really know if those are exactly the exact mechanisms for humans, and we don't know why certain seizure medications work for some people. We do know, like GABA, for instance, those receptors are underexpressed in places that are seizures, and it has to do with overexcitation and that sort of sense. But I think there's still a lot that we don't know. I wish we could figure out who responds to what seizure medicine. That would make things really helpful if we could do some sort of testing. I know there's a lot of gene testing for certain medicines out now, like Plavix and that sort of thing, to see if people are going to respond. I think one interesting thing Dr. Friedland does in the cognitive department is he's really looking at gut bacteria and how that affects neurodegeneration. I think that actually may be an interesting topic for epilepsy too. I'm not sure if anyone's looking into that.
Questions, comments?
We don't know. There's
That's how the vagus stimulation works?
Yeah, she was asking about VNS. There's a lot of theories about, it's affecting like the nucleus solitarius, but we really don't know. They just, I forget the historical perspective of how they just figured out that it did work, but we're not exactly sure. Yeah. Generally not. So the devices are palliative. So we usually only use the term cure for epilepsy with surgery. And even with surgery, only about 20% of patients can come off of their seizure medicines. So a lot of times they're still on medicines, yeah. I don't think I've ever had anyone be able to, because these are pretty refractory patients. Yeah.
Yes, sir.
So the inducers decrease the combined oral contraceptive pills, but oral contraceptive pills do not interact with the enzyme inducers. Oral contraceptive pills only decrease lamotrigine. So it's not a two-way street with the same medications.
Well, thank you so much.
Yeah.
I really appreciate it.
Yeah, thank you.
If you guys